Well, greetings again. This is Dr. Bill Wyatt with the American Orthodontic Society, and I want to cover a case here of enlarged adenoid tissue. But this is just one problem that this young man has. He has several other problems, and nearly everything you get into orthodontics, there are going to be more than one problem. So you have to deal with all of these mixed up problems that people have and correct each one as you get to. And this is why I say that the price for orthodontics should be arrived at by how much stuff you're going to have to do with the case. It's just like taking your car to the mechanic and wanting to fix, you don't just say, fix my car. You say, do this, 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 this. And that's kind of what you do in orthodontics, or should. And then that way you would pay more for something that you did a lot on, and then you wouldn't say, how much do you straighten teeth for? That's where it's come in, where people don't want to do this adult orthodontics because they have more problems, have the wear and the teeth that are lost, and ankylosed teeth, and all sorts of things mixed in with adult orthodontics. But you can learn how to do that. And I started out as working on children and doing interceptive and preventive orthodontics. So I'm going to go over this case, and as we come to the problems, I will try to explain how you deal with that particular problem. But the main problem was this adenoid tissue was just huge on this young man, and he had a breathing problem. And the breathing problem, he had his mouth open, and he swallowed and pushed his teeth out, straightened them out like this. And orthodontics is not just fixing a smile for somebody. I mean, you fix the whole facial structure on this person, and you would take this person, how can they get through life and do what needs to be done a lot of times if they look like this. Now let's get going here, and I'll try to go as I'll try to go as fast as I possibly can. Now the tongue was in the bottom arch when you're breathing through the mouth. There's no way you can do it otherwise. And the tongue spreading out in there will widen the lower arch. So this lower arch has got bigger in here, and it's the cusp of these teeth are coming up on the bottom cusp, are kind of outside of the upper cusp. And that's where we run into cross bites and have people shift from one side to the other, and you have a lot of problems with that. So you've got to correct that, and that's going to be widening out the maxilla, kind of like it would normally be, and open the airway, but his airway is closed about 50% by the oversized adenoid tissue. And then his tongue that he developed, a tongue thrust, and it shoved these teeth out like this. Now look, the teeth moved out there, and the bone went with the teeth. Now the crown of the tooth is no longer, it's just raised up out here, and the bone is tilted out here. We've got to bring that back down, level it out, and when we look at the x-rays, you'll see there's not going to be enough room in this area for that to happen, so we're going to sacrifice some of his bicuspid teeth to help do this. This is why the X up here is for the permanent tooth, the baby tooth, and the baby tooth and the permanent tooth down below. Let's look at the other side of the mouth, and this is in a class 2 relation. The bottom arch the molar should be fitting about like that on the bottom, with the bottom tooth out in front, the 6-year molar out in front of the upper 6-year molar. And you see we have some distance in here the same way. Let's go with the next deal. I don't have to erase that, but anyway, you can see what it is. Now the other side of the mouth is very similar, except the cusp of the lower teeth are inside. They're more like he shifted his jaw a little bit here. And look at the place where the upper teeth are, and we're going to bring these teeth down. And anybody that thinks you can't move the teeth where there's no bone, this is a ridiculous idea that I don't know who came up with that. I mean, like if you went to a surgeon, he could say, well, I can section this out and set it down here. It's a lot of work. You just move it down and it'll line right up in there. And over here, we're taking out the permanent teeth and the deciduous teeth. At least that's what I've drawn up over here. Now let's go on, and we got a lot to cover now. When the tongue is sliding up this way, when you're doing that and shoving these teeth out, you don't get the pressure on the sides. So this arch really ought to be out like this. And that's what we want to strive to try to do. You don't have to have a fancy cephalometric stuff to tell you what to do. You can look at the patient and see more to do than you'll be able to do in most of the orthodontic cases. But we use a large wire to do that, or we expand the guy and come on. We'll get back and show that in just a minute. Now on the lower arch, we've got a freakish kind of thing. Here is a lateral and a central that are fused together down here. And so we're going to have to make this act like it's through 4 teeth right here instead of 3. And we're going to have to work that out. But we're going to make some room if we remove those permanent teeth and then the bottom arch. And we're removing the teeth back against the, in other words, we're taking the second bicuspid instead of the first bicuspids, what we're recommending here. Now here is the young man, and when we look at him from the side, the lower arch should be out something like this. And we're going to try to advance this to some extent, and we may pull this back to some extent. We will pull it back. It's going to be coming down, and we'll correct most of that problem right there. Now, if this guy were to live his life with this problem like this, orthodontics is more than just fixing a smile for somebody. I mean, you change the whole way that person's going to live their life. If you went back with your teeth sticking out like this, what would this guy be able to do? So your orthodontic, you're correcting this, but it's not just a smile that the person gets. It's a whole facial structure is going to look different than it looks when it's like that. Now I'll go ahead and get back. Now looking at him from the front, we've got a good facial height in here, even though his teeth were flared up like that. I think we may be already in the case on this picture. In fact, we have. But I mean, we closed this gap up, and now these teeth are brought down from up here. I don't have a straight-on picture of him with the teeth sticking up like that. But if this guy went through life with his teeth sticking up like that, what could he do? He sure couldn't be a movie star, and even in business and talking to people, and he's sticking there with his teeth out like this. It makes life a difficult problem. So we try to correct this so we get the smile and the facial structure looking right. Now, we use an occipital headgear in helping us locate these teeth right here. We pull this, pulls against this, and you hook it up here, and if it's hooked on the other side, the same place, you can raise the dental arch back here, or you can cut these things shorter and pull from here, and you'll pull up the teeth in the middle, and you can pick the whole blooming maxilla up like that. Or you could take this thing and run it out to here and run across here and with a spur underneath it, and you could raise the front teeth and leave the bottom teeth like they are if you want to. Now here in this case, we wanted to bring the front teeth down. So we were pulling them down and we were holding that back up with an occipital type headgear. And we'll show some of this. Okay, we're going to get into the adenoid tissue now. And if you look at this closely, I'm going to draw it off. This is the adenoid tissue right in this area. Here is the airway. The airway is reduced quite a bit right in here. And so that's kind of robbing him from being able to breathe comfortably like that. So he breathes through the mouth and he gets some air through this way coming out the mouth. And he pushed the teeth way out like that, and we ought to bring these teeth back down. Now, you send a child into the ENT person and get the adenoid tissue removed, and usually there's some tonsil tissue down here which you can't see real plain on these cephalometric pictures like this, but probably if the tonsils are large and they're closer to, they'll take the adenoids and the tonsils out, and you just really increase the airway. Now watch, I'm going to erase that, and you can look at that and see the adenoid tissue. If you got a good light, you can see where the adenoid tissue is here. And if you had tonsils, it would swell up down in here, and you may take them both out at the same time. All right, we go, now we'll come back. Now here we put a retainer in. We've gone several months now, but look where the adenoid tissue was. Now we got an airway like that in here. We increase that airway by a tremendous amount. I'm going to back up, and you look where the airway is right in here, and you trade that in, and you get an airway like that. And that makes a whale of a difference in the amount that that person can breathe and the ease in which he breathes. And you suck in the air through the nose, cleans the air, moistens the air, and it helps in many other ways. It filters out the junk in there. A lot of times you'll swallow that doesn't hurt you, but breathing this dust into your lungs or the junk that you are working with is bad. And so you try to get it where a person breathes through the nose, and a little silica in there will catch the debris that's in the air, much of it, and clean it up. You may swallow it, and the stomach doesn't bother. It doesn't bother the stomach much. Maybe if you breathe in some really terrible air, then that might not be totally true. All right, so we're going to go ahead. All right, there's your adenoid tissue, just a closer look at it, and there's the way it looked after we had that removed. So this is where you deal with your ENT people, and you get the adenoids and the tonsils out on these bad cases. Now we look at from the panoramic view, we've got this tooth and this tooth and this tooth coming into this space right here, except we're going to move this teeth back, and that's going to reduce this space right in here. And we're going to have to put these three teeth in this area between here and here, and we're going to bring these teeth out. So we didn't have to have all this in here, but we will try to pull this lower jaw forward. We pull it forward by pulling these teeth backward, to the back, and that's going to bring the lower arch out, and it'll give him a little more chin. We can't make the chin grow, the length of the chin grow right here, but you can move it forward, and it'll cause the head of the condyle up here to kind of tilt back and let the jaw come forward, and it'll increase this gonial angle right in here. Now, this gets to be a pretty complicated case. We put a palatal separator on here. If you can see this coming across the top, I don't think I've got a picture of it, but we spread the palate back out and put the upper teeth over the lower teeth. We've done that now. You see the upper teeth are out over. And we're going to have the bottom teeth come in. They'll be out in front of the upper teeth, and that's the class 1 relation. It'll be like that. And we're doing some of that in here. The palatal separator opens this and carries the roots out buccally with the crowns. And that's where you need to keep these teeth roots coming out. You don't just push the teeth out. The points would go in like this and carry them out there. As you do, you put the palatal separator, you cement that in real solid, and as you go out, you spread the arch out this way, not this way. I mean, if you just push on it, that's the way it'll go. The points, the teeth will go together and reduce the airway rather than increasing it. But if you put the rigid place, don't put a bar in here on your separators. Put the brackets, band the teeth and have them cemented, they're solid. And when you push them apart, it'll have a little tendency to go in at the roots. But when you chew on this puts you eating on the middle, the mesial cusp of the tongue side over here, and that chewing will keep that out. So you put a palatal separator in and leave it a few months, and they chew on the lingual cusp, and that brings the roots out, even lines them up straight, and that increases your airway. Okay, we're going to go now to, here's what we decided we would do here. We've got these crowded out. See this follicular movement of the teeth right in here. These cuspids are running right into these laterals. So we take out the deciduous teeth and the permanent tooth underneath those. If we do that, this permanent tooth is in here, so we remove it and take that. Now, this right here is a fused tooth. It's two teeth grown together like that. So we do the same thing on that side. And so you clean this out. And now these teeth that were, let me go back now, look at where this tooth is pressed into this lateral root right here. This tooth right here is coming in here. You go try to put that tooth in that space. And so this one is coming along, and we take this out. This tooth will lean over, and this cuspid will come right into the space. And the follicle around the teeth will push the tooth over. And we've got videos on palatal movement of the teeth, the follicular movement of the teeth. All right, we're going to go, I'll erase that and make it look. All right, this is, I didn't get the dates on that, but that's a few months in between here. Now we've taken this tooth out. This tooth moves back to there. This is moved here. These teeth move forward. And this cuspid is headed down, and where it was jammed up against the roots of this other tooth. As it comes down, it comes in place over there. And if I'm not mistaken, we put something here to stop the tongue thrust problem. That's where the young man was pushing at. Now watch this come together now, and it'll slide. Everything's going to come forward. All right, we're pulling the 6-year molars up against this space, and here's the wisdom tooth forming here, here, and here. Wisdom teeth are forming, and we're going to trade these teeth we took out and try to keep the wisdom teeth. The wisdom tooth is in the best position for chewing, hard chewing of any of the teeth, because the muscles are right back in this area where the tooth is. All right, now we go in here and we have closed that space up. We brought these teeth down. This is the 12-year molar coming to here. Let's see, I don't have this. This is number 6. This is 10/28 of 87. I'm not sure just how old the young man is, but we've got these teeth over, and we're trying to parallel the roots of them as they go in, and this looks pretty good at that point. Now there we're going to come in, and we have the lower teeth in the position of the, see where the lower tooth is out in front of the upper 6-year molar. Same thing over here. Here's the lower 6-year molar, and here's the upper 6-year molar, right in like that. And that's the way it's supposed to be. Now, we had these banded, and we put these little tongue thrust appliances on there to break this habit of tongue thrusting. And we've got several videos on tongue thrusting where you have these little wires turned back, and that stops the tongue thrusting. You look at it, it looks like cruelty, but your tongue will go up there and hit that about 2 or 3 times, and then your tongue will just stay away from there. And you keep that long enough. You need to get the airway fixed up, though, so they can breathe through the nose and not have to be messing around with the tongue going out there. So we've got this all back now, and we've expanded the teeth up above, and he is aged 12 and 11 months, almost 13 years old at this point. Now, if you had left this case alone, which is a ridiculous, stupid thing to do, and say, well, when you get 12 or 14, come in and I'll do this, you've got problems there that you just probably won't ever overcome those problems. So you start this stuff pretty early, and you may take some time as the teeth come in. It may take a little more longer to do it, but the work is less than if you wait until this problem comes up. Now, I don't know, this is a young man. His jaw may grow until he's 20, 21 years old. Young men's jaws grow like that, whereas a girl's jaw, most of the time it's about 13 and a half to 14. That's about as far as they go, unless they have a lot of male hormones. Some young ladies will have more hormones. I had one that had a lot of male hormones, and her jaw grew out when she was 16. That was a very unusual thing to happen. But we've got a video on her too if you want to look it up. Now, here, let's go to the next deal. Now, this is getting closer to finishing, and we've got room. You see how the jaw's got out of the way now? This wisdom tooth can come in back here, and I hope this one can. Now, the wisdom tooth is off to the lingual side of the jawbone itself, so sometimes you look like you don't have the room, and the tooth will be out to the side. The tooth will be toward the tongue, and the jawbone will be out away from it to some extent. So here we take this off, and now this young man is 14 and a half years old, and this is the 9th Pediatric we've taken, and we've got room over here for the wisdom teeth for sure. There's some question about this. You keep up with the case right on through, and if you're a pediatric dentist or you're working with children, stay with those children till they're grown and finish the case properly. Don't be swapping it back and forth and have to get some orthodontist to do this, and then you do this, and that. You get them mixed up. The pediatric dentists need to learn how to do the orthodontics, and the pediatric people that are headed like that is ridiculous. They tell pediatric dentists, if you do this, you can't call yourself a pediatric dentist. Pediatric is nothing but somebody that works on kids. And if you learn how to work on kids, you'll carry it on into adulthood, and you have to learn how to do older stuff, and you can switch over or just continue working with that. Now, this is the 9th Pediatric, I think, that we took right here. And here I will go through the working of this. We just took this fused tooth and put a bracket on it by itself. These other teeth right here, we banded them and put points on them to break the tongue thrust problem in there. And we pulled these teeth down. We had probably an intruding arch, bringing that in. This is a rectangular arch. And we lined those up. And now let's watch. I'm going to go through this pretty fast. The lower teeth, we've got a flexible wire in there, and we're closing that space up in here. Now here, we go back, and this is where we're going to expand this arch. Now this tooth wasn't in far enough, but we banded that tooth and this tooth, and as these teeth go out, the lingual cusp will touch more than the buccal cusp, and the teeth will tend to bring the roots out, but this palatal separator is cemented in. If you're wearing a palatal separator, you just have a bar in here, the tooth here won't torque out, it'll just kind of lean out. You need to have each tooth, and if you got other teeth in here, this is baby teeth, you can start in, band all the teeth, and even if this hasn't come in, see, so we can't hook it up yet, but I had this one hooked up, and we cut this thing off right here, and so we're expanding that the upper arch to meet the lower arch. Now here is the tongue thrust deals, and this is a fused tooth. We put one bracket in the middle of this, and these have the bicuspids are removed right there, and we're going to open this up. Now we move those fused teeth into place, and we've got room now. If the cuspids come in, we'll finish closing this down. We're going to bring this down and bring these teeth together right here. Like we will come in and we'll pull these down by pulling the lower teeth forward and trying to give him a little bit more chin for his facial structure. All right, this is down. This is a fused tooth. It's almost lined up. I need to rotate it a little bit more. We want it to come in that way, right there, and line up better, and we've just about got this space. The second molars are coming in back here, and we've got room for the wisdom teeth, we hope. All right, here we finish this young man out now, and here is what this person would have had, and here's where we got to with these teeth. Now, this doesn't just give this guy a good smile, it changes the whole personality of this person. And that's what orthodontics gives you, a really satisfaction being to do that with people. And look at it from the straight, and look at these fused teeth. He'll go, most dentists won't even notice that when they come in here. His bite's closed down. And you change this whole person's life. And you ought to stay with him and watch this for a few years and have him wear a retainer to hold it in place. And this is what you finish up with. And that's the lower arch. And there's the fused teeth right there. You won't even hardly recognize them. And the 6-year molars and the second molars, and he has room for the wisdom teeth. I don't think I have the pictures far enough down the line, but here he is later on. And I want you to sign up for our program that we have here, and we thank you for watching, and I hope this gives you some insight in the complexity of orthodontics. And you think, well, I'm just working on these kids, but they grow into adulthood, and you should follow this on. He doesn't have quite the chin I'd like for him to have, but he looks great. And this won't hamper him in life. He can be a television announcer with this smile that he's got now, and the whole facial structure if you left it alone. So we'll say goodbye, and I hope you'll subscribe to our channel. And thank you for watching again, and I'm going to close this out.